Okay, so let's talk about acute COPD.
Ooh.
All right, so you get two real spectrums of COPD, right? You get this kind of chronic bronchitis, but then you also have this emphysema picture, and they all sort of physiologically overlap with asthma because, it's difficult to tell the difference, and sometimes they have both, et cetera. But
which I think will also help people understand why certain drugs don't work that should. Or
right.
It's like, well, this person has more bronchospasm, this person has more lung destruction, so
Right.
nothing works. This person
Right.
has more, so
Right.
it helps people
Knowing
understand.
that difference is key.
Yeah.
We'll talk a little bit more about that next too. And the one key thing is that this is a chronic inflammatory disease, and they're not fully reversible. Like their lungs are just functionally different, typically from having smoked for forever,
Right.
and often continue to smoke despite having COPD. And so if you think about the number of people that smoke, 15 to up to 50% of people will develop COPD at some point. So it's a big deal. And if you can get them to stop smoking, it'll prevent all of this, right?
Right.
So again, so these two clinical spectrums, you have the pink puffer, right? This more emphysema picture. They're generally thinner. They have less of the cardiovascular diseases that are associated. They have more hyperinflation. They have more dyspnea and decreased exercise tolerance over time, versus this blue bloater where it tends to be somebody who's got a higher BMI, they're more overweight, they have more of the metabolic complications and comorbidities associated with that. They get cardiac issues. They oftentimes also, because they're overweight and often obese, get OSA on top of their COPD. They're less hyperinflated, and they get more of this like chronic junky bronchitis cough picture. And they tend to often get more exacerbations as well. And so, there's sort of two spectrums of COPD. And so kind of knowing this will help a little bit later on. We kind of talk about management. And this is sort of another picture of how there's a blue bloater and a pink puffer, and sort of differentiating these. And then the complications are sort of what I want to get at here. So for the pink puffer, right, the emphysema person, because there's more bullous disease, they are more likely to develop pneumothoraces and complications from that. And so you can imagine like intubating someone or putting positive pressure when there's already lots of bullae that are ready to pop. Maybe not the best idea. Whereas in contrast to the blue bloater, a lot of times these patients have this chronic hypoxemia, and they develop this polycythemia vera as a way to compensate for it. They oftentimes, because they're overweight, they get OSA, they get pulmonary hypertension as a result, and you get this reactive vasoconstriction from the hypoxemia, this sort of vicious cycle that keeps continuing. And you can get cor pulmonale from the chronic pulmonary hypertension too. So it's like neither is great, but you can understand the complications based on which side they might be on. So for exacerbations, right, this is really defined by worsening respiratory symptoms where they can't do their ADLs anymore, right? And often the triggers are very similar to other things like asthma, but can be infectious, either viral or bacterial. It can be irritants like smoking or something in the air or an allergen, wildfires everywhere. And then things that can make them hypoxic can definitely like push them over the edge, cold weather, even certain medications, right? Like beta blockers we know can do this, opiates.
New glaucoma meds.
And so you want to be kind of thinking about, well, if there's a trigger, what could it be? Is this something that's preventable in the future? And it can give you an idea of what to do to prevent the next episode, right? So, and speaking of infectious triggers, this question of prophylactic antibiotics has been up in the air forever. And it's hard to know because it's, in healthy lungs, there's always stuff like colonizing everything.
Right, your lungs are not sterile.
Right, your lungs are not sterile. Like there's bacteria and viruses living amongst us, in us. And so it's like, at what point do you give an antibiotic is a really tough question to ask. And so the idea was that for patients who have COPD, they're more likely to develop an infection from these things that we are normally colonized with. And that was the idea for giving them prophylactic antibiotics and thinking maybe this will reduce future infections and complications. And so, it's hard to know, but, that is out there.
Yeah, and again, thank goodness it's the pulmonary docs that have to make that decision, and we don't, but it is something to know, to ask about if they're on chronic antibiotics, because it may change what you're worried about as far as resistance and things. So assessing for somebody who has a COPD exacerbation, it's examine history, right? It's like everything else we do, it's examine history. But you're remembering that infection is often the trigger, or one of the more common triggers, is to ask about any kind of signs or symptoms of an infection. So pneumonia certainly can do this. And I'll tell you, sometimes, especially in somebody who's a pink puffer, somebody who has a lot of lung destruction, finding that pneumonia is hard to do sometimes.
You can't hear much.
You can't hear much, and their lungs are often so destroyed. You'll see big bullae where there's no more lung left in that area. So sometimes it's a little hard to find it. But it is worth asking in your history, and we do ask this a lot, is ask about their sputum. So, how is your sputum changed? Is there more of it? Does it have a different color? Is it, is it more purulent? Ask about that, because it may be your only real clinical sign that whatever is down there living in there all the time now is causing a problem living in there all the time as far as the organism is concerned. Now, that may be fine to help you figure out the trigger. If that happens, if they have the sputum change, that cup is nasty.
I can't look at this picture.
So there's a picture of it.
Gross.
For those of you that are just listening, I'm going to describe this absolutely disgusting cup. That's my least favorite body fluid. We were asking people,
gross.
That's my least favorite body fluid.
Yeah.
It's just gross. It's just, there's like a lot of body fluids. That's my least favorite. But anyway, there's a cup of sputum that's shown on this slide. Medical cup,
gross.
not like a drinking cup, a medical cup of sputum. But if you have this sputum that changes, like it's more of it, it looks purulent, it's green now instead of being clear, does it benefit to give those people antibiotics? So they've done a couple of trials in this, and frankly, it is underwhelming.
Yeah.
Completely underwhelming. The antibiotics really make a difference as far as exacerbations are concerned. It's really, really underwhelming. Yeah. So that's kind of a shame. I would love to have be the magic answer.
So now it's like, do you give it chronically? I don't know.
Yeah.
Do you give it for acutely? I don't know.
I don't know. Although the sicker they are, the more likely I'm gonna.
Exactly.
But it doesn't mean I'm going to give it to everybody. And and there was a time, by the way, the guideline said
you gave it to everybody.
Yeah, and that has and again, that's not a good use of antibiotics. No. So then we have studies that say it doesn't work really well very much anyway. So this idea of nobody knows if it actually works, their practice guidelines right now basically say, it's a common practice, but it's really not worth doing in general. Ask about it. The sicker they are, consider it, but otherwise not so much. So how else can I figure out, somebody who has COPD exacerbation? Is there anything else I can do that helps me figure out if this is actively what's happening? So beyond the H&P, there's no magic. And frankly, I have to tell you, I have COPD. I am having more trouble breathing today. They're a little bit wheezier than they have been. There's no other thing I'm worried about. Like they suddenly have chest pain and I'm worried that they've thrown a PE or they're in congestive heart failure. It's like, okay, I don't think it's that hard to make the diagnosis. Should a blood gas be involved? Frankly, no. It doesn't really, unless they're super sick.
Exactly. I think that's really the only key is if they're coming in, they're super sick and you want to sort of trend something objectively in addition to their symptom,
right?
Then maybe get a blood gas, but
not otherwise. For everybody. And if you get one, a V BG is just fine. You don't have to get an A BG. And I'll show you a table that will prove that to you in a second. PFTs is I think PFTs are looking for a place to be. They're looking for at least in the emergency department to be. And they just need to
respiratory therapists are I need job security.
Exactly. So. But they need to go get job security somewhere else in the hospital because that is not the place to be doing PFTs. It doesn't help in COPD at all to do these when they're having acute exacerbation at all. Asthma is questionable. Maybe it might help, but COPD, forget it. Forget it. And should we be sending cultures? Oh my gosh, let's just culture everything. Well, no, actually, if I gram stain and do a culture on an asthmatic sputum, it's going to grow what I know it's going to grow, which is going to have some H flu down there. Yeah. Is that H flu just living
colonized?
There?
Right.
Is that it doesn't guide me at all. It doesn't do anything. Now that VBG ABG thing, there was this kind of idea for a while of, oh my gosh, it needs to be an A BG because that's so important. This is just one study of all comers that got an ABG versus a VBG. Lots of different reasons that they got this particular thing done, but and this also came from Europe. So if you look at this table, there are KPAs on there. Line that out. We'll ignore that. That's actually a European measure. We're going to look at the stuff that we're used to, like millimeters of mercury, of things like PO2 and PCO2 and pH. So it turns out we know that the PO2 on the venous side is lower. Duh. Mm-hmm. So I'm just going to ignore that. I'm not getting it for that right now. Right. I can do a pulse ox for that. I don't need it for that. But does it help me in the pH? Yes. VBGs and ABGs pHs are very similar. Good. And clinically, that difference of 0.04 is clinically irrelevant for virtually everything. So that's fine. The PCO2, the difference, the AV difference is about 6 millimeters of mercury. And frankly, that also probably makes no difference, although it's not insignificant. So a PCO2 of 52 versus 46. I might say, are they retaining a little more? It might make me think twice, but frankly, I'm not using it anyway, a blood gas in most cases. And if they're sick enough that I think they need that, I already know what I'm doing. I'm going to be doing some interventions anyway. So that's fine. The other things about diagnosing COPD exacerbation, there's I wish I had like the magic tricorder. Woo, it's COPD, not CHF or not a PE. There's no magic to that. So BNP may be helpful in differentiating. Is this person who has both heart failure and COPD, what's Which it today? It might be useful in that case, although some of the data on that says it's not so good either. Lung ultrasound might definitely be useful. If I see a whole bunch of B lines that make me think you have pneumonia or a congestive heart failure exacerbation, and I'm not so worried so much about your COPD, that may be helpful. That's great. D-dimer, oh my God, the road to hell is paved with D-dimers.
Oh no.
So it is. So seriously, D-dimers, and Andrew's going to talk a little more about PE in a second, but just don't get, I'm just going to get it just cause in a COPD exacerbation. Please don't get it in anything just cause. Make sure you know why you're ordering a D-dimer. It can be a big problem. And then end-tidal CO2s, you would think these would be useful to follow. And they're easy, right? Stick them on a little end-tidal machine, watch it and see. There's not a lot of great data that says it helps me know you're having exacerbation. I think there's some potential with studies getting done now that might be useful there, but right now it's not clinically helpful.
So regarding PE testing in COPD exacerbation, so there was an observational study that talked about, PE was more prevalent in patients that were admitted for COPD exacerbations, 5 to 6% prevalence.
A lot.
Pretty.
Like 1 in 20.
Yeah.
1 in 20 people, you missed a PE.
How
Dr.
dare you?
Wu, how dare you?
Dare you? And so they tested all admitted patients for COPD exacerbations for PE. And in this multi-center randomized control trial of 746 patients, so, it's decent size.
Yeah, it is.
It compared routine PE testing to just usual care. Like, were you suspicious? Okay, then you go chasing and testing. But the readmission rates, the deaths, the VTEs were all unchanged. So the bottom line is, only if you're suspicious for PE, then pursue the testing. By no means test everybody who's coming in for a COPD exacerbation.
This study that came out and said, you ignorant people, how dare you be missing so much? It was not at all clear when those PEs happened.
Right.
Did it happen while they were in the hospital?
Exactly.
It was not at all clear. So God bless the people that said, okay, just wait.
Calm down.
Let's do a real study on this and see what's what. And that one basically said, we're fine to do what we've been doing for a long time. And everybody else needs to just chill.
Right. So X-rays, I think, is a little bit different from the other topics we talked about. So the chest X-ray is actually helpful because these patients do get pneumonia and they do get pneumothoraces and they do have other complications. And so looking at the chest X-ray can actually give you a lot of information.
And they're prone to all of this. This is part of their disease.
Right.
It's not just some
They're
random...
hyperinflated. There's bullae, right? You can get this flattened diaphragms from just having such enlarged lungs. And you can look for infiltrates and pneumothoraces. All of this is going to come out of your chest X-ray. So it is helpful for COPD, not for asthma, not for bronchiolitis or URIs or any of that, but specific for COPD exacerbations, chest X-ray is helpful.
Yep.
Great. So this is a very classic picture of the bullae and blebs and the pneumothorax that happens afterwards, right? It can be sometimes hard to distinguish what's just a giant bullae versus an actual pneumothorax.
Really can. That's where old X-rays are helpful.
Yeah, and then you could get a CT scan if you're really trying to figure it out. But these are impressive.
And I think the main thing that take home is if you see one of these, don't go charging in with anything that pokes through the chest.
Especially if they're doing okay.
Yeah,
like,
just
think about
hang
it for
out
a second.
Maybe get something that verifies it
Go
truly
look at an old chest X-ray.
Exactly. Because it's tempting, but it's not good.
Yeah. So this is another picture of a pneumothorax and COPD. This one is, so this goes back to sort of like these patients have baseline awful chest X-rays with crazy bullae. And so getting an old X-ray or some other imaging for comparison is really helpful, right?
Because that X-ray on the left, you'd say,
holy
that's a tension pneumothorax.
Yeah.
But it's not.
But it's okay. Yeah.
It's just big bullae. That's incredible, actually.
It's crazy. This is another one. Like, wow.
Oh, crazy. I look at that, right? You'd be tempted to go ahead and stick a tube in there, but just don't.
Yeah.
So if that's the case, how do we treat COPD? Well, everyone who's practiced for a nanosecond of emergency medicine has been taught about this idea of hypoxic drivers, that bad people have bad COPD. What drives them to breathe is hypoxia. And if you suddenly give them a lot of oxygen, they'll just stop breathing. Physiologically, that doesn't make a lot of sense, frankly. If you think about what drives your breathing, and this idea is somehow a COPD is magic and they reset their respiratory center where now it's triggered by oxygen rather than CO2, which is what all of ours is triggered by. So they looked at this actually, and I tell you, if you practice long enough, you've seen this. So the person who's given the nebulizer, they're plugged into wall oxygen, and the next thing you know, they have slid off their chair, they're on the floor, they're CO2 narcotic because they are hypercarbic. I've probably seen a dozen of those now in my career because it is real. So it turns out this hypoxic driver thing is real. So in most cases, it doesn't matter. In most cases, if you stick them on a nebulizer and they have wall oxygen as the delivery system, in most cases, it's not going to matter. But every once in a while, it's going to be that person that basically they decrease their respiratory rate, they increase their CO2, they get CO2 narcosis, and they get knocked out.
And they
forget to breathe, and now you're in a crisis moment where they're now something you have to think about intubating.
It's similar to like the respiratory distress kid that like looks like they're in respiratory distress and then suddenly they're not. It's sort of similar here where like you've given them oxygen in whatever shape or form, and then they're building up their CO2 and they're forgetting to breathe, and they look quieter and calmer. Like it should give you some pause.
Yeah, they should be getting calmer slowly, not all of a sudden.
Not all of a sudden.
Looking like, oh wow, life is cool, and now I'm going to go to sleep and stop breathing.
Right.
Which is what they do. So this is real. This is absolutely real. And the reason that it's taught in this is that there are times where you should on purpose ask respiratory therapy or the nurse or yourself to get the other meter and plug it into the yellow thing in the wall instead of the green thing in the wall, and use the room air or the air that comes out, because that you don't add any extra oxygen. And I'll tell you, just take seeing one of these, and you will never ever forget again that sometimes you need to do that. And frankly, it's not a bad default in someone where oxygenating them is not an issue. It's just dilating them is an issue. That go ahead and use just the room air. Beta agonists, go ahead and absolutely use them. Okay, stapled. It's a go-to. And no, remember we talked about the fact that some people are more on the blue bloater end, some people are on the pig puffer end, some people are on the sort of bronchospasm end. You may not get a lot of bang for your buck for giving a beta agonist, but it's part of the cocktail you're going to give. So you're going to give it and cross your fingers that it's going to work. Anticholinergics do tend to help if they will respond to those kinds of things. So great. Nobody knows we know continuous in asthma is better. We don't really know if continuous or intermittent's better or not in COPD. If they're sick, give it continuously, that's fine. We also have not compared meter dose inhaler and spacer to nebs in a COPDer. I have no reason to think they're different, but I know the nebs work, so I may stick on the nebs with those just because I'm comfortable with that, and that's what I know. And then parenteral stuff, like do I need to use sub-Q or IM epi in these people if they're really sick? Who knows? Nobody studied it, and they probably haven't studied it because most of these people are older. And often have other things like cardiovascular disease or cerebrovascular disease. So nobody really knows. I'm not sure I would count on that to be my magic for somebody who's bad, especially if they're not responding to an inhaled beta agonist at all and they have all these other lung issues going on. I'm not sure that would be my way to go. Steroids, though, are a yes. So steroids are absolutely a yes. Now, so again, you're bang for your buck on this. Some people won't have a lot of inflammatory component to their COPD, but if they do, they get a good bang for their buck on this. So just go for it. You're going to go ahead and give steroids in exacerbations. Overall, they improve oxygenation, reduce relapse, reduce treatment failures, shorten hospitalizations if they need to stay. So just do it. This is a just do it sort of thing. Absolutely. Again, oral and IV doesn't matter. Go ahead and just give it. It doesn't matter. This one, though, probably needs a longer course than just a single dose Dex. And that makes sense. They have a chronic inflammatory, always there problem. You're going to need to keep that thing under control. So that's fine. And adding an inhaled agent is absolutely fine. They're often on it anyway. So do both. That's absolutely fine.
Right. We talked about how antibiotics are controversial, and especially for these outpatients, the literature is really weak in this area, and there's very limited data. There's one that says maybe it reduces mortality in the critically ill patient, right? So, I mean, I'm not going to let that type of person go upstairs with an antibiotic. They're getting antibiotics.
Right.
But that logic was sort of extended to all admitted patients. And I think that's a little bit overkill. And studies have shown that as well, right? And then this whole idea of what is the limited amount for course that is necessary? And they found that 5 days or less is probably just as effective as longer.
Right, but not single dose.
Correct.
Yeah.
Right. And then talking about the other things, right? So CRP and procalcitonin have been studied, all in an effort to try to figure out who really needs antibiotics and who doesn't. So CRP theoretically reduced antibiotics in 2 trials, but most guidelines have not adopted it. It's still not recommended. I don't think it's really good enough yet for us to really
I
get
really
to
have
that
never heard
point.
anybody doing this.
No.
Which
And then
tells
same
you, I'll
thing-
tell you, ER docs are practical. It's like,
It's like, do I really need to,
No.
right? And then same thing with procalcitonin. The idea was that you could reduce the antibiotic usage for those that actually needed it. And they had high procalcitonin, they therefore must have had a bacterial infection, but that didn't pan out in
No.
these for future trials. And then it just was maybe associated with increased death. Like, so ultimately it's like Procal, CRP, none of it is
All
really
these
helpful
non-specific
in
things
figuring
turn out to
out
be
who
really
needs
disappointing.
antibiotics. Yeah, it's really kind of too bad. Like, I wish there was a good test, but there's not one yet.
Yep.
And then there's other things, right? So magnesium, either IV or nebulized, maybe. I think there's some thought that it could reduce admissions for a COPD exacerbation.
especially the IV.
This was it's the IV. I don't think anyone's giving nebulized mag, but the IV mag, like if I'm getting them upstairs and admitted they're sick, they're getting IV mag.
Yep.
There's really not much of a downside, as we've said before, and all the different other. And so multiple drugs, other things have also been tested. This is more just an FYI that like statins don't work.
Yeah.
Vitamin D doesn't work. PPIs also have failed. So like these are not a thing.
Yeah.
And specific to oxygen therapy, was going back to sort of what we talked about in the beginning of these hypoxic drivers. You don't want to put them into CO2 narcosis by like giving them this, like having them lose this hypoxic drive to breathe. And so you really want to aim that pulse ox to be 88 to 92%. And
For real, like focus on that.
like and like get everyone on the same page, right? Like the shift change nurse or the one that's covering, everyone is aiming for this number. Like it's like on the bed, because you will find that like somebody who doesn't know, they think it's something else.
They look it up and it's 91%. And they're like,
oh, must turn it up.
Yeah.
Right. And that's where you get in trouble.
That's where I want to be.
Right. And so it's like, you got to write the order, you got to put it at bedside, like whatever it takes, make sure everyone is on the same page about this, because it will cause patients to tip over and start to get hypoxic and have an increase in the CO2.
Oh, it's a nightmare too. You don't want to intubate these people. So, especially for that reason.
Right. Oh, I know. Iatrogenically done it. Ugh. High flow nasal cannula. So, this is something that we can consider. It's shown to have long-term in-home benefits, and it maybe prevents COPD exacerbations. For a patient who's acutely in an exacerbation, maybe with mild hypercapnia, there was a study in China that talked about how there wasn't a benefit in that patient population. But then there was another study in the European Lung Society that did talk about non-invasive positive pressure over high flow. And so it's
so what you're getting is the positive pressure problem that's helpful, not the. So I will tell you, my read on this literature is no.
Right.
And it makes sense pathophysiologically. Why? COPD is often not just an oxygenation problem, it's a ventilation problem, and more often the ventilation problem than the oxygenation problem. And all high flow nasal cannula does is oxygenate you.
Yeah, exactly. And that can be troublesome sometimes in these patients too.
Exactly.
Right. And then the non-invasive positive pressure ventilation, there's more literature to show that this is helpful.
Oh, yeah.
Right. It reduces mortality. It is generally something that reduces their work of breathing as well. And so it's really great to use in a way to avoid intubation, like some 80% were avoided.
Right. So this is considered first line by the GOLD group, the National Heart, Lung, and Blood Institute. So this is literally COPD exacerbation, especially anything more than just mild, and even mild, but definitely moderate or higher. You slap this thing on them and it decreases intubation by 90%, decreases mortality by more than 50%.
Right.
I mean, you get so much bang for your buck on this, that this is a go-to number one.
Right. If you don't have a contraindication to having this, like try it, right? Like, so if they're not at an aspiration risk, if they're not altered, it is
hypotensive.
Hypotensive, exactly. If they have like weird facial anomalies, like, it's worth trying this because it does decrease their work of breathing. And oftentimes for these sicker patients, it will save them an intubation.
And save them an admission sometimes. I mean,
that's
true.
That's true. They've had people turn around.
Yeah. Yeah. Yep. So to summarize this one, to just the take-home points that, a lot of good pearls in here, but the take-home points. We know that COPD exacerbations are common, dangerous, and they're often triggered by infection. And frankly, having COPD is, as far as your risk of death, is right up there with cancer, frankly. It's a really terrible thing to have. So we want to do our best to, when they have these exacerbations, have them get past this one to the next, to live on. The diagnosis is usually clinical. There's no magic diagnosing this, but do remember that there are triggers, not just infection, but remember pneumothorax can happen, especially in that person who's the pink puffer, who has all this bullite everywhere. Pneumonia is one of the infections that can be a trigger. And PE, if it clinically is relevant, not just everybody, but if you clinically think they've had a PE of whatever reason to help you decide it's PE. Be careful with oxygen, okay? Be careful. Go ahead and go crazy with beta agonists and steroids. Go crazy with that. Non-invasive ventilation, go crazy with that. But watch the oxygenation level. Your goal is sort of 88 to 92%, so don't let it get too much higher than that, or they may stop breathing. Antibiotics, if they're admitted, sure. Outpatient, it's kind of you make the call, but most of the time, frankly, it isn't particularly useful unless you have a really good reason. Magnesium maybe will help with admission. It's not quite as exciting data as it is in asthma, which isn't fabulous there either. So magnesium, if they're super sick, sure, but otherwise, I'm not sure that it adds a lot. And I do want to re-emphasize that idea with non-invasive ventilation, because the data is so compelling on using that early and preventing so many terrible things that happen with exacerbations that is absolutely worth grabbing first as you're grabbing your drugs as well.
Yeah.